Good. All right, so Patellar had a total knee replacement done
July 8th.
July the 8th. So, 6 weeks.
Okay.
Okay. I actually had the privilege of working with Patellar prior to her total knee replacement.
Okay, old friends.
She's had arthritis and stiffness in her knees for a long time, but actually not much pain. So that's why she was able to push off the total knee replacement for a while. I'd say pre-operatively, she probably had about 85 to 90 degrees of flexion. Normal's 135. So anything we can get past that now is improvement. Her gait pattern is she walks with very stiff knees. She's had to go ascend and descend stairs sort of sideways for a long time. So yeah, Peter Caprice in Lynchburg was her surgeon, a really good surgeon. He actually volunteered some time at Lynchburg College. And yeah, she had her checkup on Wednesday.
Incision.
Yeah, go ahead and take a look at her incision. It's really well healed everywhere except for we have a little spot where the Band-Aid is. So there is a little bit of wound care that I still do.
How far post-op?
6 weeks.
Okay.
Good. And then she's got some adhesions in the incision. So I'm actually going to use some traditional Chinese medicine tools, some cupping, to work on the incision today, and I'll show you how to do that.
Neat.
So she's supine. I find that this is a great position for her, for really total knees in general, to get flexion back.
But you're doing great.
There's basically two types of manual therapy,
Do that one more time.
at least in my opinion. There's the type that reduces pain, and there's the type that
All the way there and back.
improves motion or improves movement.
Kind of picking out stuff.
Okay.
But if you need to look down,
Medella's never complained really about pain, so this is about her getting flexion back. And that incision can get sort of bound down and can keep her from getting flexion back.
Okay.
So I've mobilized her patella before, done a lot of incision mobilization, and then I will actually measure here as well on a regular basis.
then we'll go with this today too.
So I call this sliding cupping. So it's a kind of a traction manual therapy,
Okay.
as opposed to pressure. Most manual therapy is pressure based.
Okay.
That's why I like the traction, because it's just different, feels different, and gets really good circulation, blood flow to the area.
Cool.
Some therapists will use like small plungers.
So it's basically what it is, right?
Yeah, it's basically like a little plunger.
Hope they can hear the squelching noise on the camera. How does it feel?
Good.
Feels good?
So back to basic biomechanics, one of the things I'm thinking about trying to increase knee flexion is that screw home mechanism of the tibiofemoral joint, being that the medial condyle of the femur is a little bit bigger. So when we go into knee flexion, I want to do a little bit of tibial internal rotation when I do passive motion. So we'll do some passive motion here next.
So this is all just trying to loosen up the adhesions and mobilize the surgical site so that you can work towards restored range of motion.
For sure. Yeah, well said, Professor Sanguilini.
Thank you very much, Dr. Reagan.
Now, if you feel her incision, there are just some spots that are adhesed or have an adhesion.
Kind of a lumpy feeling.
Yeah, that's why it's just important to get that motion back, because the connective tissue in the skin, that can resist motion as well.
Just focus. Stay engaged. Hey, that's
Go ahead and
okay.
straighten out.
Thank you. You got as long as you can recover, you're fine. There we go.
Here's the patella. There's some patella mobilizations.
Zoom in on that.
Great, Charlotte. Great. Turn.
You do what we done last time.
Yep, go back through.
All right.
And it might,
So So basically, he's manually shifting the kneecap to the position that he wants it in.
So kind of, I mean,
Kind of keep an eye on
yeah,
everything.
it's kind of.
I really just don't want it to be stiff. That's all. So the kneecap can get stiff and resist flexion as well. So it's not even about really positioning too much as it is just about, I just don't want it to be stiff.
It's always kind of gruesome the first time you see the patella manipulated.
Yeah.
I remember the first time, it's like, wow. I feel
Yeah,
like
and some people lose an awful lot. But I'm sure there's some females in your class that have had recurring subluxations or dislocations. You know, athletic adolescent females, that's a common problem. They have laxity in their joints.
Is that usually congenital or is it?
Yeah, I think it's genetic, DNA nature. I think physical therapy can be simplified as really there's a continuum of the nervous system, so parasympathetic and sympathetic on opposite poles. And so with that comes low tone and high tone in muscles. I think that's really more DNA driven, and you can change it with exercise and taping and bracing and stuff. That's basically how we look at changing the way someone moves or helping them move better. Is for people who are low tone and more hypermobile and hyperflexible. We're going to add exercise, taping, bracing to increase their tone, increase their position, their alignment, their posture. Then there's folks who are high tone, you know, neck pain, think like, you know, upper trap tightness. With those folks, we're going to work on trying to decrease their tone. And so there's lots of manual therapies to do that. All right, so here I'm going to brace the distal femur, a little bit of tibial internal rotation, and then knee flexion. Total knee replacements, I think, are the most painful thing I work with. And it's one of the few cases where I think traditional perspectives of physical therapy being painful, that T word, torture. It's the only time I really feel like that.
The patient agrees right now.
And I personally hate that part.
Yeah. Well, you're here to make her feel better, and
right. And I do
fortunately,
everything I can for Mandela to feel as comfortable as she can be.
So you're good, kind of.
I'm not taking pictures of your facial expressions, Mandela. I'm just on your knees, so contort away.
Okay, deep breath.
They got it in the hospital, they got it turned around.
All right, deep breath.
I'm actually going to potentially be good at this.
Okay, hold there.
So stay healthy.
Could you tell us what that is, Dr. Reagan?
It's a goniometer.
Goniometer. Doesn't love a good goniometer.
About 95.
I'm gonna pause this one there.